Bitten up to now, just to carry on summarising, is the Delphi study into looking at the problems of diagnosing autism in adult women, of normal intelligence and verbal ability, looking at the problems of differential diagnosis and how to diagnose complex cases. So I was just saying that the person's difficulty should be corroborated by an external informant who knew them in childhood, and failing that, then there certainly should be a third party there. The concept of autistic traits is useful to explain to a patient why diagnostic threshold is not reached. However, a minority opinion was that there is a possible slip into we're all a little bit autistic and that diagnosis is categorical, so you either are autistic or you're not autistic. Autistic traits is not a thing. I would actually kind of agree with that minority opinion. I sort of feel that someone who's sort of sub-threshold is simply not autistic, and I do feel that it's a categorical split between those who are autistic and those who are not. However, in reality, because there's no blood test or brain scan, this can sometimes be difficult to disentangle in cases that are kind of where the person has maybe appears more superficially neurotypical. It might be harder to disentangle, but I would say actually that any very well trained clinician who has access to a lot of evidence from multiple sources, I would say should be able to disentangle what is actual autism from what is someone who appears autistic-like but actually isn't autistic. But I do feel there is a difference. I think it comes down to, first of all, the extent of clinical impairment, for starters. Clinically significant impairment. If someone is not clinically significantly impaired, as far as I'm concerned, they're not autistic. The question then is obviously how do you determine clinically significant impairment? And I guess, in very clear-cut cases it's quite easy, but it gets a lot harder the more normal a person appears, I guess, and the more normal their life is, to make that call. It's not, I would say, because we don't have a blood test or brain scan, it's difficult. But that doesn't mean that categorical autism isn't a thing. It just might mean that our tests are not quite accurate enough yet to determine who's actually autistic from who isn't, and that's something that needs to be developed. There's a clear belief or hope that the assessment will result in an autism diagnosis. So the patient could have a clear belief or hope that the assessment will result in an autism diagnosis, and this could be seen as a potential source of bias, where the person seeking diagnosis would describe their life history through the lens of the research they had done, and it cited tests such as the Autism Spectrum Quotient that's widely available online, and sometimes a person has already done that test online, and that could potentially bias some of their responses, particularly if they desperately want an autism diagnosis instead of, let's say, a more stigmatising assessment. This could potentially kind of bias some of their responses, and that's why it's so important that a clinician delves deeper to find evidence from childhood, to interview multiple sources of information such as parents or other people who know the person well, just to make sure that the person isn't just saying things they've read, but this is a real thing. That's so important. I've already said that autism is considered to be less stigmatising than mental health diagnoses. And there's also no consensus with regards to the camouflaging thing, by the way. There's also no consensus as to whether camouflaging had to be observable by the clinician. For example, social differences observable once the person is tired, or say spontaneous social interactions, where there's a breakdown in camouflage and then you can start to see the autistic behaviour, or whether the person's description of camouflaging sufficed. So if a person's description of camouflaging sufficed, then you could have a situation where an autistic woman or man, but this article is specifically looking at autistic women, so you could have an autistic woman who says, I'm camouflaging, so they're appearing really socially normal, really socially normal, but they're camouflaging, and you just go by their say-so. How do you know then? And you're not detecting any autism signs. How do you know? Because you're just going by the person's word, that's circularity. So that is why you shouldn't just go by the camouflaging thing, and presumably no good clinician would do that, one would hope not. That's why they should look into the person's history. There needs to be a history there, and that history needs to be from childhood. Like in my case, I have a childhood history, I was diagnosed special educational needs when I was at school. That didn't really get the help I needed when I was at school. But I guess but I was assessed, by an educational psychologist when I was 9. I had a thorough workup, neuropsychological workup when I was 9. All the evidence was there. It's very indicative of a child with kind of classic Asperger's, really, when you look at it. So that's evidence. That's neuropsychological evidence. So we have that from the school setting. For psychologists noted my problems, for teachers noted my problems, occupational therapists noted my problems. It was recorded. It's there in writing from when I was a child. Then, of course, you had my parents at the assessment talking about things that I didn't know about, because they can, obviously I can't remember what I was like as a baby or 1-2 years old, but my parents can. All that evidence was collated over several visits, and also I saw quite a few different people: psychiatrists, speech and language therapists, psychologists. So it's I had quite a thorough assessment, and that's what I wanted, because I didn't want to just be diagnosed with autism, without good reason. I wanted to make sure this was correct. This was a correct diagnosis. That was really important for me. I knew there was something developmental going on, because I had, the assessment done from when I was a child and everything. But I wanted to make sure, I wanted to have a correct diagnosis. That was really important to me. So having childhood evidence is really important. I suppose it is a lot harder if a person presenting doesn't have that evidence, if they weren't assessed for special educational needs as a child, if they didn't have a psychological assessments of that nature when they were a child. It can be a bit harder, and that is why it's so important for clinicians to really delve deep. And if there isn't such an assessment available when they're a child, maybe to conduct an adult assessment. They can conduct an adult cognitive assessment, or there are various tests that can be used tapping into comprehension of things. It needs to be done thoroughly. Anyway, so thank you for watching.